The topic today is recurrent implantation failure in IVF, and this is the Canadian Fertility and Andrology Society Clinical Practice Guideline, published in Reproductive Biomedicine Online. It's actually not out yet. So this is in their advanced articles section. You can access it if you just download their app, and that's where I get them from. So all you got to do is download the app and then you can go from there. Okay, so the first issue that we deal with in recurrent implantation failure is that absolutely nobody agrees on what recurrent implantation failure is. Is it 2 transfers? Is it 3 transfers? Is it 6 transfers? Is there an age dependency in there? What if you've had fresh versus frozen? So nobody agrees on this, and because of that, every study has different criteria, and so there is no uniform definition of what constitutes recurrent implantation failure. To me, it actually very much depends on your center. If your center has really good success rates, maybe recurrent implantation failure for your center is 2 or 3 embryo transfers. If your center doesn't have great success rates, and many centers don't. Some centers have a 30-35% live birth rate for their IVF program. If that's the case, you may need 2 or 3 cycles of IVF before you get to the point where you would call it a recurrent implantation failure. So it's center dependent, and I don't think anyone's ever going to come up with like a uniform definition, because it's impossible to apply what you get in one center to another center. So if we look at some of the best centers, if they're just doing it after 2 embryo transfers, or 3 embryo transfers, that's going to be very, very different from a center that needs to go through 2 or 3 IVF cycles where they may have 6 or 12 embryo transfers. So very, very different results, very, very different criteria. And so you need to know that when you analyze this kind of study or this kind of data. Okay, so I'm going to pull it up for our friends on all the social media formats that are not Instagram, because you guys can see it. For everybody on Instagram, I'm going to be reading out some of the stuff to you. Okay, so the first thing they looked at was cavity assessment. So should we be investigating the inside of your uterus for its shape, pathologies like polyps, fibroids, scarring, which can lead to recurrent implantation failures? And the answer was they looked at hysteroscopy, and there was a study called the Trophy study, 350 women with 2 to 4 previous failed IVF cycles, and they looked at half the group that had hysteroscopy versus the group that did not have hysteroscopy. So in that study, they did find anomalies in up to 24% of the women, but for some reason they said that they couldn't actually operate on all of them. Only a small percentage were operable. They said only 4% was operable. Now, is that because they couldn't do it during the hysteroscopy because it was in office, or because of the skill of the surgeon? They don't clarify. But certainly, you know, in the hands of an expert, if you see something at hysteroscopy, it would be kind of crazy not to deal with it. And if you're good, you should have no trouble dealing with it. So whether it's a T-shaped uterus or a septate uterus, Asherman syndrome, fibroids, polyps, I mean, I deal with all of that stuff all the time, and very soon we're going to be actually having our own hysteroscopy facility here on site in the office. So we're really excited about that opportunity, assuming the government gives us the billing permission to do so. We'll be moving it out of the hospital so we can help you folks out a lot sooner than we can right now with COVID and the hospital situation. So bottom line was, they said that for hysteroscopy, there was no benefit to doing it because they found the same results in the group that had the hysteroscopy versus the group that didn't. Now again, not a great study because they weren't dealing with the pathology that they found, even though they actually found it in 24% of the people that that were evaluated hysteroscopically. They don't, however, discuss anything about the saline infusion sonohysterogram. And you really can't justify not doing a saline infusion sonohysterogram. Done properly, and we have a great YouTube video where one of my favorite patients showed the actual process. We videoed it, doing it on her live. She's not complaining of any pain. She has no discomfort. We get a great image from it. It's super easy to see. And if done properly in the right hands, a saline infusion sonohysterogram is painless, effective, gives you tons of information, can show you if there's any abnormalities in the uterus, and really should be part of that RIF evaluation, but they don't include it here in the guidelines. So that's the first one. Let me scroll up just to show you guys where we're talking about this. So this is the very first one. Shows you right here where it says that cavity assessment, not really important. So the second one they looked at was thrombophilia screening. So thrombophilia screening is where we check you to see if your blood is thicker than it's supposed to be. Some of you may have heard of this with factor V Leiden, antithrombin 3 deficiency, methyl tetrahydrofolate reductase enzyme deficiency. So there's all sorts of different anomalies. The lupus anticoagulant or antiphospholipid antibodies. So the largest study they looked at was pretty old now, about 8 years, 594 women who underwent up to an average of 7 failed IVF cycles. So 7 whole IVF cycles, kind of crazy. I would never even do that many on a patient. So they looked at those who were tested and were treated with anticoagulation versus those who were tested and not treated, and were treated with anticoagulation. None of them had a prior history of blood clots. And again, they did not show a significant association between the clotting disorders and the outcome. So they said testing for it doesn't help. They do later on talk about treatment for it and say that treatment for it actually is equivocal. They can't tell for sure if it works or not. So right now they say it's a research setting question. So I'll get to that in a minute. What else about testing? They looked at immunological testing. So what about doing immune testing to see if that's helpful? So these are those really expensive tests, usually somewhere between $1,500 to $2,500 Canadian to test for the natural killer cells many of you will have read about. CD56, the T helper cell 1 to T helper cell 2 ratio, all of the interleukin levels, complement levels, and so on. So in this case, they say that it should be limited to research settings because, and you can see it down here, recommendation number 3, because they're not sure. They're saying that there is alterations in the immune profile, and you can see it in the write-up here. It says several serological immune profiles may play a role in patients with RIF. Antibodies against placenta-specific 1 protein may impair implantation, have been shown in a small case control study to be associated with recurrent implantation failure. Same thing with interleukin levels, interferon gamma levels, all sorts of different things, transforming growth factor beta. So there are some levels in proteins and chemokines and so on which may be associated, but they're not sure. And so they're saying maybe it's worth it, maybe it isn't. If you talk to reproductive immunologists like my great friends Fred Zineku and Chloe Remain in Toronto, amazing pair of reproductive immunologists, they will tell you that in certain circumstances this is really important. I know I send my patients to them when we're thinking immune stuff, and they find stuff sometimes, and then we address that appropriately. And with their sort of protocols, they are seeing very, very high success rates in populations where most people are seeing very poor success rates. What about genetic testing? So this is the karyotype analysis. This is a no-brainer. If you have recurrent implantation failure or recurrent pregnancy loss, you need to be tested. Why? Because a certain percentage, albeit low, but nevertheless present percentage of patients will have abnormalities, especially translocations or balanced translocations. And when that happens, you need to have the appropriate treatment, which is actually specialized IVF with pre-implantation genetic testing for balanced translocations. And the Create Fertility Clinic I work with in Toronto just pioneered a new technique where you actually can see which ones actually carry the balanced translocation versus which ones are normal. So there is some really amazing work going on out there, and kudos to Dr. Librak who came up with that with his team. Okay, what about sperm DNA fragmentation testing? Well, no one's ever really shown that DNA fragmentation testing is associated with recurrent implantation failure, so it's not recommended for that, but we do recommend it for couples who have unexplained infertility, and we recommend it for couples who have problems with recurrent miscarriage, because it is a huge increase in your miscarriage risk if you have high levels of DNA fragmentation. So DNA frag is more and more becoming mainstream. I still don't believe it's indicated for everyone. If you've got perfectly normal sperm, you probably don't need to do it. But for everybody else, if there's sperm compromise, history of recurrent miscarriages, you need to consider doing the DNA frag, because it will potentially make a difference for you. So those patients need it. What about doing chronic endometritis? So chronic endometritis is, again, very complicated. This is inflammation or infection in the lining of the uterus. The criteria for diagnosis, again, does not exist. No one agrees on what qualifies for chronic endometritis. So it's really hard to know if they're making a difference or not. So the results from this one, they said there are no trials that compare treated versus untreated. And they did see several studies that showed sort of very small results, and they say they're very susceptible to bias, although there is one big meta-analysis that suggested that there was a benefit. So again, they say it should not routinely be offered. I do take an exception with this, and that is that this is looking at chronic endometritis where you biopsy the uterus and you're looking at pathology. We know that that can miss actual infection in up to 50% of cases, if not more. So the real way to do this is to actually look for bacteria or viruses in the lining of the uterus. We now use a company called Fertilis. It used to be called Locus Medicus, which is out of Greece. I own no stock, as usual. I always have a disclaimer. I don't work for any company but my own. So they have a website, www.fertilys.com. Their test is called the Hidden C, and they have a 12-in-1, and then you add on HHV6. Which is human herpes virus 6 to the equation. So they can actually test for the presence of the RNA from the bacteria, viruses, yeast, all of that stuff, and look for it in the endometrium simply by sampling your menstrual blood. And that's a really valuable test, because if there is infection in there, that has all sorts of risks for failure, for complications with your growth of your embryos, for miscarriages, and even late miscarriages, where we've seen women that have had results where they'll deliver their child at 18 weeks, 19 weeks, 17 weeks. I just did that not too long ago for a patient that very tragically suffered a 19-week loss. And she had not just one, but 3 different bacteria in her uterus, which we needed to deal with. So all of those are really important. So I do disagree with this statement. I think that chronic endometritis testing maybe isn't that valuable, but testing for bacteria is. What about the ERA test, the endometrial receptivity array? So they say here that it's only usable for research. There is minimal data to support it, and within the last week there were 2 more studies that have demonstrated absolutely no value to doing the ERA test. So for those of you that are still hung up on the idea that the ERA test actually works, the ERA test is useless. It's been proven to be useless by the company's own study. Multiple other trials have shown that it's useless. It's useless. Don't waste your money on that test. It should only be used when you have really thin endometrium and we can't tell if it's even receptive at all or not. But do not use it to date your endometrium or to alter the timing of your endometrium, because we've reviewed on the show other studies that show that there is no difference in outcome whether you do a transfer after 5 days or 6 days of progesterone for a day 5 embryo, and that day 6 embryo should be transferred after 6 days. So saying that your endometrium is receptive at a specific time doesn't even make sense when you're looking at the receptivity in relation to the timing of the embryo. So skip that stuff. Do not do it. It's a waste of time. Okay, what about pre-implantation genetic testing? Well, they're saying that there is insufficient data. As you know, and we've reviewed this on the show, PGTA testing is not useful for women that are less than 38. But whether or not it's useful in a group where they have recurrent implantation failure is a different question. If you are taking a euploid, in other words, genetically normal embryo, putting it into a patient and they're still not getting pregnant, there's probably something wrong with that patient's system somewhere. It's unlikely to be the embryo at that point. It could still be, but it's unlikely to be the embryo. And so as a result, you really need to take a look at what the possibilities are in terms of problems with the patient, which may mean that you need to actually find a carrier. So I think it's reasonable to consider it in this circumstance, but there's not enough data to talk about it yet, so there's no randomized controlled trials. They then go on to treatments. So what about endometrial scratching? So this is the biopsy. So we've covered this on the show before too. I'm going to keep this short. They say it's insufficient data, but the bottom line is every week someone publishes a study that says, yes, do it, and next week they say, no, don't. So I think the jury is out. They say that the two most recent trials showed that there wasn't a benefit, but after these, there was more data that showed that there actually was a benefit, again, in randomized controlled trials. So I would not tell you to do it or not do it, although aside from the 5 seconds of pain, it's relatively harmless. So if you want to try it, go for it. It certainly doesn't do any damage as far as we know. Okay, what about taking heparin or aspirin, anticoagulants? Again, they say that it should be limited to research for heparin, and the aspirin, they say, is the same thing. It should not be routinely offered. Again, I'm going to say that there is enough data, in my opinion, to support trying it, especially when you've got recurrent implantation failure. It's not easy to just keep telling patients, you know, there's nothing that can be done or we don't know. Sometimes if it's harmless, it's reasonable to try. Heparin and aspirin together have been shown in some studies to be beneficial. And while it's not without its share of discomfort, there is really no damage from taking heparin and aspirin together. It doesn't really increase your bleeding significantly enough to make it harmful to you. Aside from the stinging and bruising from the heparin, you're generally okay. So I think it's worth considering. Immune therapy is the next one that they decided to tackle. This is a big topic. They actually don't say anything about it specifically, but they go through a bunch of different ones which they looked at. So they said there's very little data for IVIG therapy, intravenous immune globulin. We've just started using the subcutaneous in some patients. I think you really need to have data to show that there is an immune problem before you do this with the IVIG, because it is incredibly expensive. For the subcutaneous IG, I think it's reasonable in some patients to try, especially if they have a history that's consistent with this. Again, as long as they don't have any contraindications, it's very safe. They got to sit here for a couple of hours, let it infuse, and then you're good to go. They looked at intralipids, and they actually say intralipids may be hopeful. Now, this is interesting to me because we've been using intralipids for over 12 years now, and we do use it in the patients with failures, and I do believe that it actually works in some cases. So I think it's very reasonable. It's super inexpensive compared to some of the other crazy things like IVIG, and so it's really easy to administer. We've never had a reaction. Everybody does really well on it. You only need a couple of treatments, and you know, we're only charging $250 for the first treatment, $200 after that. So it's very manageable for most of our patients. Other treatments that they've looked at, they looked at steroids. They say they don't know. They've looked at GCSF, which is granulocyte colony stimulating factor. They say it may be helpful, but again, they don't know. And so they're not sure about that one. And they basically summarize all of that stuff by saying they're not sure. They think more research is needed. So sum total, in terms of testing, essentially they're saying the only thing that you definitely should test for is your chromosomes. Although I disagree. I think that checking the endometrium for infections is reasonable. And I don't think that it's unreasonable to check patients for the thrombophilia screen for recurrent implantation failures. In terms of actual treatments, the intralipids and some of the immune protocols are very reasonable. There is data for aspirin and heparin, although these guys say it's research settings only to determine if it works. And the jury is out on whether or not you should do PGTA. Do not do the ERA test. Totally useless. So this isn't necessarily fact or fiction, but each of those individual things can be a fact or fiction for you. So hopefully you've enjoyed sharing that information tonight. I'm hoping that'll bring some clarity to many of you who are struggling with the fact that you've tried multiple IVF cycles and it's not working. This should give you some answers as to what reasonable next steps there are, what you should consider doing, what you shouldn't consider doing. So thanks for joining us for that. That'll be up on the YouTube channel, www.youtube.com/drvictory, Dr. Victory. And as always, like, comment, subscribe. The more views we get there, the more it helps us to bring more of this entertaining and interesting stuff for you guys.